I'm just going to welcome everybody to our Calgary ED COVID round update number 4. Thank you for joining us, and I'm going to hand over to Neil for the leadership update. Neil?
Thanks very much, Stuart. It's just that, please bear with us as we try and redevelop these admissions protocols and the algorithms. And I know Cash is going to get into these later in the program, but we really are in a developmental phase, and I'm just asking for everyone's patience as we kind of work through these algorithms. But things are, as you know, well in hand right now, and we're just adapting to the new situation as we see it. So just stay tuned for further developments. Thanks, Stuart.
Thank you, Neil. So just to get onto the agenda, we've had the leadership update from Neil. We're now going to jump into the clinical aspect, which this week is dealing with disposition and treatment of the mild moderate COVID patient that Kasia Lenz and Fagan are going to talk about. We have the question and answer ongoing as usual that Sean is going to moderate. So please remember the question and answer format. If you go down to the bottom of your screen, put your question in, but look and see that someone else hasn't posted the question already. And if they have, just vote for that question, and that will move up for Sean's attention. And then we're going to wrap up with Kelsey McLeod doing a wellness update. And now on to Kasia.
Hello, everyone. So yeah, I'm Kasia Lenz, for those of you who may not know me. And just a couple disclosures to start. Number one, I just wanted you to all know that I am not getting paid per flow sheet being produced for these admission pathways. I also want you to know, sort of as Neil alluded to this, that more changes are inevitable. We are working through all this, and I am very grateful, and we are all very grateful that you have been so flexible and understanding. So without further ado, Erin, if you could move to the next slide, please. So I wanted to talk about some of the rationale and the process behind all these admission pathways. And I do want to reassure you that I am advocating on your behalf at these negotiating tables, trying to make sure that we minimize the paging burden for you, that we make sure that the speed of admissions is reasonable and fast, and that the expectations for our role in all of this is also reasonable. One of the things that I've really been emphasizing to our inpatient colleagues is to really try to minimize that pinball consult where you consult one service, they ask you to consult someone else, and you have to consult back. So they are really trying to ensure that they're not doing that. That message has been heard. And one of the major things that will help decrease that possibility is that specifically for COVID, those pagers are being held by staff. So as we know, disposition decisions, staff to staff, usually go a lot easier. And so that should be helping with a lot of that. In all of this and all of the planning, we are lucky in that we have been able to stay ahead of the COVID curve, and we're continuing to try to stay ahead of the COVID curve. We will see what ends up happening, but that's why a lot of these plans have been implicated now when we're still not seeing these huge volumes. Hopefully we won't, and hopefully it'll all be a big letdown and I've wasted a lot of hours of my life. But in case that this tsunami ever does hit, we will have all of our issues hopefully sorted out before that happens. And I also want to reassure you that there is a massive scale-up plan. So you heard from Neil that there is huge bed capacity, but just to give you a more sort of real-life example, if at the Rocky View, for instance, we needed to suddenly boost the internal medicine's census by 80 patients now, we could have that up and ready to go by tonight. So part of that is that having a separate COVID doc, separate COVID pager really allows for easy scale up for these inpatient services, and they have worked very hard to develop some of those plans. Next slide, please. Okay, so the flow sheet. You'll see this is still saying draft. All I've changed from the last one that has been there, or all that has been changed by the inpatient services, is I just asked them in that blue bubble at the top to remind you all that this is specifically for those patients that actually need an admission. Okay, so that's what this algorithm is for. And I'll talk about going home and I'll talk about going other services in a second. I just want to focus on those patients that you believe are coming to the hospital. So updated versions of this, even these drafts, are on our department website. I ensure that there is an updated version there. As I said, this is a living document. This is constantly under evolution. So please refer to the website for most up-to-date versions. You also usually get an email from your site chiefs about this. So those are the two ways that you can get it. But if you're on shift and you're needing to make sure that this is up to date, go to the website. And right now, if you want, you can pull this up on your computer and go through it with me, or just bear with me here. So to highlight a few things, I already mentioned that this is only for patients with COVID that require an admission. You can use this as a tool to help you delineate who you're consulting. So I'm sorry that the single pager system didn't work. I guess people were getting overwhelmed by this. So we now have a separate system for consulting hospitalists and consulting the internal medicine colleagues. But when you look at this, and you've probably already realized this, a big part of this is the CURB 65 score. So the question has come up, why are we using CURB 65? And the answer is because we don't have a validated tool specific to COVID at this point. CURB 65 was developed for assessing risk of decompensation and mortality in patients who are presenting with viral or bacterial pneumonias. And it allows our inpatient colleagues to, given what we know and to the best of their ability, at least try to risk stratify these patients. It's not perfect, but it's what we're using. There's more detail in the scientific update that was sent out with the chief medical officer just a few nights ago, so you can go into more detail about it. But just know we're using this, and please play along. So if you see going down this algorithm, if you've got a patient that's got some degree of a CURB score, or you're at all concerned that they need to come in, they require oxygen, or they have a complex medical history, which we know is a risk factor for decompensation in COVID, the very first thing you should be doing before you decide to admit them to hospital is figure out what the goals of care are. And the reason being, if you look down here, and maybe Erin, you can sort of highlight this because I don't think you guys are seeing my screen, goals of care really play a role. So if they're R1, R2, or R3, if they're unstable, you're contacting ICU, and there's no question about that. If they are physiologically stable, they're not, say, on 15 liters of oxygen and their pressure is reasonable, you're consulting the IM COVID service. If they're C1 or C2 level of care, you're consulting the hospitalist service. And as we know, the Peter Lougheed has actually come out with a separate hospitalist COVID pager. Currently, that is the only site that is doing that. Everywhere else, you will be consulting the usual hospitalist consult pager, and I will just go into that at the end of this presentation. So our goals of care, IM, C goals of care, hospitalists. Of course, as usual, it's the M1, M2 level of care patients that are a little bit trickier to discern, and that's where the CURB 65 score can at least help guide us. Of course, your clinical acumen, clinical judgment still plays a role in this. As you've all probably experienced, the CURB 65 score is not perfect, but it's at least a tool. With the CURB 65, I was posing a question to our inpatient colleagues. Do they want us to use the best score, the worst score? They didn't have a clear message for us. So I think what I will say is use the worst score to risk stratify your patients there. Next slide, please. Okay, so I'll briefly touch on the patients that are going home because Andrew Fagan will be talking a little bit more in detail about this. But if you do find yourself on this flow sheet and realize that you actually have a patient that doesn't need admission, use your judgment. So I want to reiterate that patients that are not hypoxic, have ILI symptoms, it's business as usual. we have seen for years and years patients with ILI symptoms, and it's okay to not do any investigations on these patients. If their investigations are not going to change what you do not have to order them. One of the things I've really been advocating for us is that we should not be sending hypoxic patients home. I'm advocating for that at this point because we have huge capacity in our healthcare system right now. So we are not facing the same crisis that New York is, for example. Hopefully we won't get there. Our internists, I can tell you, are very bored right now. They don't have much to do, and some of them are worried about paying their bills. So if you have a hypoxic patient, do not feel pressured to send them home. There is a possibility to do that in select cases, but not a requirement for us now. Likewise, if you have a pretty well-appearing patient who has ILI symptoms, but maybe for some other reason they have a CURB 65 score greater than 2, you do not have to admit those patients if in a normal world you would be sending them home. So this is a guideline. Use your judgment. You don't have to order investigations. Next slide, please. Okay. So now for our investigations for patients that you will be admitting. These are my suggestions. So at minimum, please do send CBC, electrolytes, a portable chest x-ray, and an ECG on those patients that you're consulting inpatient services for an admission. I do strongly suggest that you consider drawing LFTs, a CRP, and blood cultures on these patients. We know that they won't all come back with being COVID positive. Some of them may have a bacteremia for some other reason. The main reason behind asking you to strongly consider this and not leave it to the inpatient services is purely to limit the number of times other healthcare workers have to go into a patient. So we're trying to minimize everybody's exposure risk. So if you're pretty sure when you start off with a patient, they're going to be coming in, if you're going to be drawing blood work anyways, in the very least, consider asking your nurse to draw the rainbow of tubes so we can add these tests on if necessary, or just send them off right away. That being said, I do not recommend that you routinely draw a D-dimer or troponin. Only do this if this is relevant. It does show up on the ED COVID order set, but again, please use your discretion just like you would in any other patients.
Hashtag,
Yeah.
Sean, it goes without saying, but COVID swabs as well, obviously, in these patients.
Oh, yes. Yeah, and obviously COVID swabs. Now at the Lougheed, you're going to be swabbing absolutely everyone because that whole hospital is being swabbed, whether we're concerned about COVID or not. And now with the loosened guidelines, we're pretty much going to be sending swabs on most people here with ILI symptoms anyways. Thank you. Okay, next slide. So even though I said this flow sheet is for patients that need an admission, if somehow you realize that they do not have COVID, there is a little note on the right-hand side for you. So you determine that COVID is unlikely. Do not forget that if their primary presenting problem is not COVID related, they should go down their regular consultation pathway. So if, for example, this is a patient with appendicitis who has a fever, you consult surgery. If surgery has concerns about there may be a risk of COVID, or if the patient was swabbed for some other reason, surgery can still consult GIM consults, or they can consult ID and deal with this appropriately. They still have access to a COVID unit if they think they need it, but the primary problem is a surgical one, and so this patient should be under surgery. Again, likewise, if you have a patient who has COPD, their cough is stable, and they happen to have a cellulitis that's causing them to have a fever, that sounds more like a hospitalist patient or maybe MTU patient if they have enough comorbidities. Please use those consultation pathways. That does not sound like a COVID patient. Do not use the COVID services. Next slide, please. Okay, so the second part of my talk is about the COVID admission form. This is something that was developed at the Foothills. The Foothills is the test site. This is purely for COVID admissions. We will likely see this play out at the other sites as well, and that's why I want to sort of give you everybody the heads up about it, even though not everyone works at the Foothills. The spirit of the form and the goal of the form is twofold. One is it is a script or a communication tool for us to use to help actually talk with our admitting colleagues. It covers most of the information they need to know in order to be able to put in an admission on a patient without even seeing them. So again, this is something that was developed with the thought that we were going to be seeing 40 to 50 admissions per sites per day. That's not happening yet, but we're trying this out now to sort out the kinks, and let me tell you, there have been many kinks. The other goal of this form is for it to be a rapid assessment aid. So one of the things I was asking is for our services to be admitting patients without necessarily seeing them, moving them out of the emerge as quickly as possible. And that makes everybody really nervous. So by filling out this form, when the patient leaves the emergency department, arrives on the ward, and say there's an hour delay till they're actually assessed by an admitting doc, if they deteriorate and someone needs to come to effectively what may be close to a code 66, they have a standardized quick form to really learn a lot of information very fast and then proceed from that. So that's the spirit of the form. As I said, we've had some difficulties. We're sorting out through this. It's a work in progress, and please be patient. I'm very receptive to feedback and trying to feed it in to our inpatient colleagues. So just keep that in mind. With that, I'll go into the next slide, which tells us about the likelihood of COVID. So this is on our website. I would like you guys to read through it once before you're actually on shift. Likely this first page makes you want to vomit, and that's an okay reaction. I understand that, and that's why I'm still working hard to change this. But really, when you look at this, sort of next to my number 1 arrow there, this is collecting historical symptoms for the patient. This is actually quite helpful. You can just circle, they have a fever, they've lost their sense of smell, they have muscle aches and joint pain, and circle anything that applies. On the far right-hand side, which may be obscured by the panelist panel there, that's where you've got the x-ray findings. The CT chest stuff, that's only if you've ordered it. I'll talk about that a little bit later. The exposure criteria is very important to circle because it helps determine where the patient goes, but also how to de-isolate them for about 10 days down the road. Then when we look down at number 2, what I'm asking all of us to consider is, given the best information that you have, try the best that you can to determine what the likelihood of COVID is in patients. The significance of this is that if a test comes back negative, we know it's not a perfect test, so this helps our inpatient colleagues determine what to do with that. Essentially, it gives us a pre-test probability. Next slide, please. The second part of the form is one that is, I think, much more reasonable and the one that makes way more sense to us. So this will likely not change much. Basically, it covers the past medical history because we know that's significant in these patients and contributes to how likely they are to deteriorate. Fairly simple, just circle yes, no for the major ones. If you have any other important issues, you've got free-form text there. The bottom part of this is the most important. This is what's going to move your patients out of the emerge department. So I've said this in previous emails, goals of care need to be discussed. In addition to an admission order, a goals of care order needs to be put in for the patient to physically leave and go somewhere else. Of course, we want the latest vitals written down. Again, this is for those patients that arrive on the ward and maybe there's a little bit of a delay and they haven't been seen yet by an admitting doc. And of course, it's time stamped. And then the last thing there is the CURB 65 score, so you can just tick it off and not have to look for it. So again, This form, work in progress. It's at Foothills right now. No other site is using it, but likely we will be asked at all the other sites to use it. In the meantime, you can still use it to help ensure that you've covered all the historical features to help more as a script with our consultations. Next slide, please. Okay, so enough talking about the form. Just a quick update for you guys that our SCM orders have changed, again, because PLC uncoupled their hospitalist and hospitalist COVID pagers. We now have some new orders. So if you look at number 1, all the acute sites are going to have the internal medicine COVID team. And this is a staff physician. So that's next to number 2 there. This is at any of the adult sites, this is what you're going to be using to consult our COVID internists. And then section 3 shows the site-specific COVID services. So we have the PLC COVID hospitalists, and the South has the emergency airway anesthesia group. If the other sites choose to uncouple their hospitalist COVID services, this is where you're going to see these pagers show up. And then, of course, number 4, at everywhere other than PLC, this is the usual pathway for consulting hospitalist. Okay, next slide. Oh, one more thing I wanted to say about this is, again, to reiterate, it's very important that we use the appropriate consulting order, because this auto-populates lists for our consultants. And again, if we have high volumes or if they're just really busy for some other reason, this ensures that their lists are populated appropriately. And so our patients shouldn't get missed, helps them look up orders while they're even talking to you on the phone. So please use these consultation orders appropriately. Okay, and then this is sort of my hodgepodge of other points based on questions and feedback that I've been getting from people. So again, thank you so much for getting in touch with me. It really helps, because I'm just one person, and then when you're on the front lines and letting me know what you're wondering about or what doesn't make sense, it really helps me clarify things. So a couple points. Number 1, CTs are not routine. So we have places to write down our CT findings. That is only if we've ordered a CT because it's been otherwise clinically indicated. So classic example is you have a patient that's dyspneic, that may have some ILI symptoms, but they also have some historical features concerning for a PE. You do end up going the D-dimer pathway, you do end up getting the CT. You've seen ground glass opacities, you have a place to circle that on the admission form, or at least discuss it with the inpatient colleagues. Do not order this routinely on everyone who you think has COVID that needs an admission. Point number 2 is goals of care. So as I mentioned, you not only should be having the discussion, but also putting the order into SCM for those patients that are going to be coming into the hospital. Question has been brought up, what if you can't get a goals of care discussion going with the patient and you can't find an alternate decision maker? Use your usual practice. So I think most people practice in such a way that if we have a pre-existing goals of care order from a recent admission, use that if it still makes sense. If you cannot find anything, you cannot reach anyone, it's very reasonable to assume R1 goals of care. And if that doesn't seem like a reasonable approach, then it ends up being a discussion between you and the admitting colleagues to figure out the best appropriate pathway. So just put the goals of care order in. Third point is that the COVID test is not perfect. So Sean was trying to get sensitivity and specificity data from the lab, and they're unable to release it because currently our test is also the gold standard test. So we cannot compare it to anything. There have been cases in Calgary where a patient accidentally got 2 swabs just a couple hours apart. One came back positive, one came back negative. So this tells us that this is not a perfect test, whether it's through the actual test way people are doing the test or the test characteristic. We can't always trust it. So people have been asking, how long do I wait if someone had a test 3 days ago and now they're presenting and feeling a lot worse and that test 3 days ago was negative? We can't give you an answer. all we can say is it's not unreasonable to repeat it if you have enough clinical suspicion to think that perhaps that first test was negative. Fourth point there is that rapid, of course, is still going. If patients are coming from other sites, the goal is always to bypass the emergency department, but I think many of us can appreciate, especially with COVID, these patients can deteriorate quickly, and transportation times aren't always immediate. So an internist may get a call about a rapid patient, and then 10 hours later, when they're not even there, that patient arrives. So whenever possible, whenever feasible, patients will be bypassing the ED, but our usual rapid process may still apply. So if a patient being admitted to another service needs to touch down through Emerge, please make sure you put your name on. Please make sure you facilitate the usual disposition of the patient and help as much as possible, or help determine stability to go to ward. And then my final point here is, please, I've put this out in an email, but just to reiterate, please keep COVID patients on your list, even if they have an admission order or a bed request order, if they have not yet been seen by the inpatient team. This is part of our two-way street of they're trying to do the best they can to actually put in orders as soon as we give them the consult so that the patient can move off. They want to make sure that the person best aware of the patient and best able to manage them is managing them for as long as possible. So if nobody but you has seen the patient, you keep them on the list until they physically leave the department or until an inpatient attending doc has assessed them. This is a courtesy and also helps to ensure that people feel comfortable putting in those admit orders on patients for us without having seen them. Next slide. That's it. So I want to thank you for your attention. I want to thank you for your patience. I promise I am trying to advocate for you. I do hope the volume of change slows down, although given our projections, we may have to increase the volume of change again to sort of undo all of these changes that we're doing. That's not happening yet, but it's possible. But yeah, and please keep sending me your feedback. Either email me, catch me on shift, or send stuff through your site chiefs. So with that, I will pass this on to Andrew Fagan, who is in the southwest suburb of Fernie, and we'll be chatting probably at the Q&A section. Thanks so much.
So I don't want to take up too much of your time, guys, because I know it's been a long morning. So this is just a brief update on some issues surrounding the treatment and management of mild disease. A lot of this stuff has already been covered in this presentation. So mostly what we're going to focus on is a few questions and concerns that have come up. So the first thing and bottom line is that mild COVID illness is really no different than any other ILI illness and should be treated basically in the same way. The second big plug that I want to put in here is for the scientific advisory group. I know Tom Rich put the link out in the chat feature. There's a lot of good resources here for use. There's so much information being disseminated around on foam sites and things. It's hard to keep it all straight, but this is a great thing for people to continue to use here with AHS to kind of keep us all standardized. So next slide, please. So this has kind of been mentioned already by a number of people, but this changed on the 13th of April, right? So now in Alberta, we're testing anyone and everyone with the following symptoms: cough, fever, shortness of breath, sore throat, and runny nose. So I'm sure most of you knew this already, but just to make sure we're all on the same page. Next slide, please. So we've kind of talked in bits and pieces about the workup for these patients. And like I said, the bottom line is that you do the exact same thing for these patients that you would do for any patient presenting with mild ILI illness. These recommendations specifically come again from that scientific advisory group. And as you can see, there's no specific investigations or diagnostic imaging that are required. And there's been no one test or prediction tool that can help determine who might deteriorate with this disease. And so as Kasia mentioned, it's using your clinical gestalt to try and determine who you think should be admitted and who shouldn't be. AHS is recommending short periods of observation within the ED to kind of get a better sense as to which way the patient might go. And then finally, the big thing, and I'll talk a little bit about this further on, is arranging good follow-up for any patients that you're concerned might deteriorate in the coming days. Next slide. We have received some questions regarding radiology for these patients and whether or not we should be doing chest x-rays on all of them or on none of them, or what we should do. So again, this is another document that's come out from our radiology colleagues that's trying to clarify this for us. And basically, as I think most people probably are doing anyway, chest x-rays should be reserved for trying to determine whether or not a patient's got complications related to COVID, or to try and delineate whether there's some other etiology for their respiratory symptoms. This document also contains a section looking at the process of getting a chest x-ray performed in the emergency department. And basically, what the radiology department would like us to do is that if a patient is COVID negative, but has influenza-like illness, they can be sent down to the radiology department, taking strict IP&C protection measures to make sure that we're not spreading any other respiratory illnesses. However, if their status is unknown, their swabs are pending, and or they have COVID positive swabs, they're asking us to perform radiography within the emergency department. So again, that document is out there. You can have a look at that yourself. Next slide, please. So treatment options, we were hopeful when we were putting this talk together that there would be something out there that we could use to help with this. I had a long conversation with Mike Parkins this week regarding this. And again, the bottom line is that we don't have any specific treatments directed specifically towards COVID at this time. The big one in the news, obviously, and I've gotten a few questions from patients on shift as to whether or not we would recommend putting people prophylactically on hydroxychloroquine or treating COVID with hydroxychloroquine. As I'm sure you're all well aware, there's no good evidence out there yet to suggest that we should be doing this. And AHS has made the recommendation that hydroxychloroquine should be reserved for clinical trials only. And I would agree with that. You'll see the link, or the link on the bottom there. There is a trial going on within Alberta run by Michael Hill. It's the Alberta Hope COVID-19 trial. This is being headed up by Public Health, so we don't need to specifically enroll patients in this or do anything when we send a patient home. But I am mentioning it to my patients so that they can look into it. And, you know, again, we don't want anyone to fall through the cracks and then, and it just, part of their, if you go into their trial and look at part of their screening process, they do send people to read information on the website. So that's just something that I've been doing for anyone who's asking about the use of hydroxychloroquine. Next slide, please. The final big question that's come up is regarding follow-up for these patients that we're sending home. And so this is the pathway being used by the PCNs currently. And so there is work going on within our department. Myself and Walker are looking at streamlining an emerge process, ideally dovetailing into something like this, so that if our volumes go up and we're having to discharge patients, particularly patients that were a little more uncomfortable about, the elderly, those with comorbid disease who don't currently meet admission criteria, that we have a nice, streamlined, and safe way for these patients to be followed up. So as more information becomes available in this, and as this pathway gets further delineated, we will let you know. And that is basically all that I have to say. So thanks again for your time.
Okay, thanks, Andrew. That was great. Thanks for the work you put in on that. And I'd just like to particularly thank Cassia for all the hard work that she's been doing, the time and hours that she's putting in to try and make this process better for us. We really appreciate everything you've done, Cassia. Just going to now get to the question and answer section. Looks like most of the questions that have been asked have already been answered. Sean, I'll hand over to you.
Yeah, so I think thanks to Neil for answering most of the questions thus far. Maybe I'll just quickly summarize them and we'll disseminate them to the group afterwards. First question was from Chris Rebus around the form that's completed for query COVID patients and whether this can be used as the primary form of documentation. As it stands, it's not an official AHS form, but if Neil commented that if you put a sticker on it, it will be considered part of the permanent patient record. So if you are using that as your primary form of documentation, just make sure there's a patient sticker on it and refer in your ED notes to that charts for further information. Another question from Ben was with respect to whether the hospitalist can admit directly from rapid consults. And that's not been the state in the past, although there is some work with HealthLink and Neil exploring this option, especially for patients who are being admitted primarily for isolation reasons or vulnerable patients. So that is something that's being explored. The final question that we had from Denise Watt was with respect to the pathway. So the criteria right now to enter the pathway is still restricted to confirmed, probable, or possible patients. What about those ILI patients where clinical suspicion is high, but they don't meet one of those COVID defining categories? Do you go down the usual referral path? And the point is yes, and most of those patients will go down that same pathway.
Can I add one thing there, Sean?
For sure.
So that, as Denise pointed that out, and in my mind, that is a problem with the algorithm, because you can still have high clinical suspicion, but their definitions are pretty narrow, and it will still send patients down that right arm. In my clinical experience, I was talking to the hospitalist about a patient that was going down the right arm of the algorithm, and they didn't want to hear from me. They said that should go to the COVID pager. So there's still, the algorithm has not penetrated down to the frontline hospitalists and MTU residents. They're still balking at infectious respiratory admissions that go to the general services. So it's a work in progress. Hopefully the penetration of the algorithm will get better as the weeks go by.
Can I just jump in here as well, since I'm intimately aware of all this? What I want to say is that I've been pointing out that sort of fallacy down in our algorithm. To give you an example, if someone had a CT with ground glass opacities and they've got fever and cough, and but they just happen to not know anybody with COVID and not been exposed, they would be considered unlikely. I pointed this out to our services yesterday, and I think the language around this will be changing. The problem is the definitions that are there are sort of public health definitions, medical officer of health type definitions, which don't always correlate to the real world. So we are aware of this, and I did point out that this will send all the patients down, say, the MTU pathway. I think at different sites you're going to experience different things. Foothills is probably going to be more rigid about this. I know at the Rocky View, if this still seems like a very likely COVID patient, the COVID people will be very happy to deal with it. They are very underworked, and I think that's the same case at most of the other sites. So it's not a great answer, and that's why we're still working on this and trying to sort it out. But we have identified that as a problem, so we're aware.
All right, thank you. That's all the questions. Again, we'll summarize these and disseminate them back out to the group and update anything if things change. We'll lead into
all right, excellent. Thank you. Just going to move on to Kelsey McLeod and the Wellness Hub update for this week. Thanks, Kelsey.
Hello, everyone. So first off, just wanted to give a quick shout out. Thanks to everyone who's stuck around for the end of the Grand Rounds. I know that kind of traditionally, wellness topics have been considered more soft medicine, but hopefully by including them in Grand Rounds, we're helping to emphasize that physician wellness and mental health are integral parts to our clinical performance. So this has also really been brought to the forefront as we're dealing with the pandemic. So how we are feeling as human beings and how we communicate those feelings to each other, our colleagues, and our patients obviously has a significant impact on the care that we provide. So if you've read the newsletter this week, under the wellness section, there's a link to a short survey. We want to make sure that we're giving information that's pertinent to everyone, and that's our goal with the survey. One of the most important questions we have on there, it's only 3 questions long, but we're looking at what things have been causing you anxiety or what fears you've been experiencing. This is really important to us because it helps us to figure out what our hub should be focusing on and how best to support you, our colleagues. So on that note, I'm going to share a quick story. The story is about a 65-year-old man who has a history of a previous type A aortic dissection, rheumatoid arthritis, and hypertension. So he's on cardiac medications, including an ACE inhibitor, anti-lipid medications, other blood pressure medications, as well as he's on warfarin and Plaquenil. So this is kind of the clinical vignette of my dad, who has given me permission to share his medical history, even if it will be posted, that's fine. And I guess the reason that I'm bringing this up is because thanks to the COVID working group, as well as kind of reassurance from our leadership, you know, a lot of my fears and my stresses around clinical management of sick COVID patients have been improved. So I feel better about managing those patients. And instead, my mind is now focusing more on my personal fears. And so I bring up my dad's story because that's something that I've been worried about. I'm worried about my dad's access to his hydroxychloroquine, which has already been cut. He can no longer get his 3-month prescriptions, has to get them in 1-month aliquots. I'm scared that he's at a higher risk of developing or acquiring COVID, mostly because now it's in High River and closer to Cargill. But I'm also scared about how the system might see him. How I see him as a really fit farmer, you know, totally high functioning, really active, runs everyone's lives. So he's a really fit guy. But I can see how on paper, only looking at his medical comorbidities, he could easily be written off by our system. And so that part scares me as well. So I expect that my experiences with the stresses of COVID are not unique. In speaking with other people, a lot of the stresses that we're having are not necessarily around us managing sick COVID patients, but instead around the environment that we're living in. Many of the stresses people are having are coming from the grind of what it's like to continue with the current way society is functioning. We're isolating, we have disrupted schedules, homeschooling kids, not seeing our friends, parents, or loved ones. And in addition, we have really no idea how long this is going to be our new normal for. So dealing with all of this over a sustained period of time is going to require a type of resiliency that many of us haven't needed before. So if we can go to the next slide, we are looking at building resources for that resiliency development. Many basic techniques are ones that Sarah, Nadim, and Farine have focused on. And they've addressed in our previous wellness rounds. Sarah talked about breathing techniques. We've emphasized the value of our peer support team. And we've also talked about resources for exercise and sleep, all of which are available on that Slack app or the Slack channel down there that's in the newsletter. And the big thing that I want to emphasize is that if these or other techniques aren't quelling your anxieties, please consider speaking with a professional possibly through the physician and family support program. I think anxiety is a normal symptom to have at this time, but if it's becoming a big part of your life, impacting your work, impacting your home life, then I think you may be at a point where you'd benefit from some professional advice or counseling. And that's allowed and that's okay, but it's not okay to just have to suffer by yourself. So ultimately, the Wellness Hub, we would like to know what your concerns are, what your anxieties are, what's stressing you out so we can help address them. So please consider filling out our survey. The link for the survey is in the newsletter and will be posted on the ED page as well. If we can go to the next slide. And so lastly, connecting with other human beings elevates the mood. So if you are free tonight, please consider calling into our CDC event, which is COVID Does Cocktails. It's a Wellness Hub event, and we're gonna be making drinks, all of which can be made without alcohol as well. We're gonna be talking about TV, entertainment, and hopefully not talking too much about the coronavirus. So the Zoom link's in the newsletter. That's all from me. Thanks for your Wellness Hub. Wash your hands. Bye.
Thanks, Kelsey. Look out for the COVID drinks. Sounds like a great idea. So just to wrap up, thanks for joining us for the rounds again. We are doing a palliative care update next week with Dr. Jen Hughes. She's going to be talking about palliative care during the COVID pandemic. Please send us any questions that you have, and then remember to check the Spectrum app that's been updated and is a great resource for use during the COVID times. Thank you very much to everybody that took part and all the time that was spent putting into this presentation. Thanks to Aaron and the PLP for making this happen. Thank you. Bye-bye.